Okay, good afternoon. Welcome to the meeting of the Joint Conference Committee for Laguna Honda for April 9th, 2024. And Mr. Moritz, will you call should I do the land acknowledgement first?
Oh, no, it's okay. I will do roll and then I'll do
Yeah.
the land acknowledgement. I'll start with you, Commissioner Guillermo,
Present.
Commissioner Green,
Present.
and Commissioner Chow.
Present.
Thank you. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. The second, would you like me to call the items, Commissioner? Or would you like to call
Sure.
them?
Yeah, thank you.
Okay.
You should go
The
ahead.
second item on the agenda is the approval of the minutes of March 12, 2024.
Okay, can I have a motion to approve?
So moved.
Oh, second?
Okay, are there any public comment?
There are, give me 1 minute. I just had, it just disappeared from my thing. I need a second to find them. And I apologize. Everyone, we're having some technical difficulties today, so please be a little patient with us. We appreciate that. All right, so there's one caller. And there's no one in the room. Is that correct, everyone? I can't see.
There's people in the room, but none of the members of the public.
Okay, great. So, caller, you're unmuted. Please let us know that you're there.
I am.
All right, please
This is
begin.
Patrick Monetshaw, Code AA. These meeting minutes accurately reflect my testimony. The March 12, 2024 Executive Team Report wrongly stated recent survey results showed improvement from prior CMS monitoring surveys with overall less findings and findings of lower scope and severity. That's bonkers. Indeed, data being released today shows citations against LHH had yielded at least 9 deficiencies since decertification for FTAG 656 involving development of patient care plans, at least 4 deficiencies and since decertification for FTAG 684 involving quality of care, and at least 19 deficiencies and since decertification for FTAG 689 involving accidents and hazard prevention. If not more for each of those 3 FTAGs. Those 3 FTAGs were just cited as violations in the actual harm severity and scope level for the 2 falls uncovered during site visits on January 28, 2024, February 8, 2024, and February 28, 2024, in which one of the 2 patients who fell from a low bed died within 2 hours due to not utilizing 2-person assist during patient care, as ordered. Thank you.
Okay.
That was the last public comment for this item.
Okay, great. And so if there are any questions or comments from the commission, members of the commission, okay, none. So if we can have a vote, right?
All those in favor?
Aye.
Aye.
Great, thank you.
Any
Minutes
opposed?
are approved.
Okay.
We can move on to item 3, the general public comment.
Okay. Is anybody in the?
Is there anyone in the room who would like to make general public comment? I don't see anyone.
No, we have a public comment for number 4 and number 7, but not for number 3 so far.
Okay, great. There is a member of the public online, and I will unmute him.
Hold on, Mark. Zoe, is that for item number 3? Okay, yeah, number 4. Okay, go ahead, Mark.
Great. All right, caller, please let us know that you're there.
I am.
Please begin.
On March 19th, 2024, the Health Commission announced an LHH team, including Jennifer Carton-Wade and Toy Williams, will receive a Good Government Award on April 25th. Their selection cheapens any and all value of this award. The award citation asserts Jennifer and Troy were instrumental in saving LHH. That's nonsense. LHH hasn't been saved, despite the 1,000 corrective action milestones. The pair haven't secured $200 million in annual federal funding. This is all make-believe. Following LHH's 2019 patient sex abuse scandal, the so-called LHH 60-day reform plan, written and co-developed in August 2019 by SFHN's Chief Quality Officer, Troy Williams, and San Francisco's Director of Public Health, Brent Colfax, was a disaster. Jennifer's LinkedIn profile states she was an assistant hospital administrator in LHH's C-suite in 2019. Troy's and Jennifer's failed 2019 leadership and the flawed Troy and Colfax 60-day reform plan led directly to LHH's decertification in April 2022. They shouldn't receive a managerial excellence award now after manager ANG LHH into decertification. Troy's reform plan asserted LHH would apply for Joint Commission accreditation. LHH never needed to hold CHAHO accreditation, illustrating Troy's total unfamiliarity with SNF requirements. SNFs require state licensure, not accreditation. This LHH JCC should take note that as of April 5th, 2024, CDPH responded to a separate records request saying, CDPH still doesn't have an AIT enrollment application for Carton Wade, who appears not to be enrolled in that mandatory preceptor-guided and monitored 1,000-hour training program to obtain an NHA or ANHA license. Counting from today's date of April 9, 2024, Carton Wade has just 75 days remaining until June 23, 2024 to sit for and pass the state and national nursing home administrator exams within the required 12-month period following her hire/promotion on June 24, 2023 for the minimum qualifications requirement in the job posting announcement for her ANHA gig at LHH. She was wrongly handed without licensure. Thank you. Agenda item 4, LHH Executive Team Report.
That's the only comment for this item.
Okay, we can move on then.
Okay, item 4 is the executive team report.
Mr. Pickens?
Good afternoon, Commissioners. Roland Pickens, Director of the San Francisco Health Network and Executive Sponsor of the Laguna Honda Recertification Effort. As usual, I'm joined here in person with our Laguna Honda Nursing Home Administrator and Chief Executive Officer, Sandra Simon. In addition, we have leaders of Laguna Honda online and available to participate in today's report.
Mr. Pickens, I apologize. I need to give Zoe permission to present. So if you could just pause for 30 seconds, she should have permission as of now. I apologize. Please begin again.
Thank you very much, Secretary. Again, Roland Pickens, San Francisco Health Network, presenting on behalf of Laguna Honda. We'll move on to the first slide. So before I begin with the full executive report, I'd like to provide a brief update on admissions to Laguna Honda. Since announcing our recertification in the Medicaid program, we have received many questions about what this means for accepting new admissions at the hospital. This, of course, is an excellent question because we know the critical role that Laguna Honda plays in the healthcare system of our city and county. This is also why we are working tirelessly towards Medicare recertification. Let's be clear, full recertification is both Medicaid and Medicare. Without being fully recertified by CMS, Laguna Honda, our current and future residents, their families, and the public cannot be reassured we have achieved final validation, legal certification, and stamp of approval from CMS that Laguna Honda is providing the highest level of safe and regulatory compliant care. However, our teams are working tirelessly towards recertification. And as we await full CMS recertification, teams are working to prepare for it. We're going over admissions plans, processes with a fine-tooth comb. We've also reached out to former residents who were transferred as part of the recertification process, and we're pleased to share that many have expressed an interest in returning to it. For those former residents who meet criteria for skilled nursing care, they will receive the first priority for new admissions to Laguna, as we have previously stated. Once fully recertified, Laguna will incorporate any CMS feedback into admissions policies and procedures that will be presented to this JCC. And we will continue to update the JCC, the Health Commission, and the public on Laguna Honda's admissions planning process. The second update I'd like to give is regarding the 2 plans of correction that were submitted in response to 2 deficiencies that were received last month. We mentioned those at our last meeting. We are pleased to share that both California Department of Health and CMS have accepted those plans of correction. Laguna Honda submitted robust evidence, and the CDPH team and CMS had several follow-up questions to those plans. This approval reflects the importance of the ongoing improvement work taking place at Laguna and brings us closer to full recertification of CMS. Currently, the Laguna Honda team is preparing to receive a plan of correction revisit validation survey, which we have been anticipating since late last week and can occur at any moment. We anticipate that we will successfully complete the plans of correction validation revisit survey and fully resolve these validations and deficiencies before Laguna Honda will be fully recertified by CMS. As we stated before, it's important to remember that once Laguna Honda submits plans of correction, we have no control over the timing of when CDPH and/or CMS will approve, which they have, but now validate, which we're awaiting, the successful completion of those plans of correction, which are the precursors for full CMS certification. Next slide. So I'd also like to update the JCC on the status of discharges for those current Laguna Honda residents who no longer require skilled nursing level of care. Teams have continued to actively work towards discharge for some of these, the most challenging residents, who, while they no longer have skilled care needs, still require care that often does not allow them to return to their home setting. Since we began discharges for 2023 upon the direction from Federal Health and Human Services, Laguna has discharged a total of 24 of these residents no longer needing skilled nursing care. And currently, there are 41 residents remaining at this category who no longer need skilled nursing level of care, most of whom are awaiting levels of care at the RCFE, resident care for the elderly, or RCF, resident care for individuals under the age of 65. Next slide. And as typical, we always provide the JCC with an update on our key hospital statistics on admissions. Of course, there are 0 discharges for the 14-month period. Here you see the number of discharges and the number of expirations during this period. Current average census for the month of March is 432. And next slide. Would also like to update the commission on some recognition about the improvement work at Laguna Honda. Last month, there was a presentation by Sammy Simon, our nursing home administrator at CISO, along with Don J. Kim, our director of Kaizen Promotion Office, where they presented at the annual Lean Improvement Conference. They presented on how Lean transformed a decertified facility on instilling a culture of continuous improvement and sustainability through the development of people. So we congratulate Sandra and young Jay for sharing the learnings of Luna with a national audience. And then finally, I'm happy to report that today, Troy Williams, Director of Quality and Chief Nursing Officer for the network, is attending the annual CMS Quality Conference. Troy was invited by CMS leaders and experts in quality to participate on a panel where they are presenting on the topic of recertification of Laguna Honda Hospital and Rehabilitation Center on the process to improve systemic operations, ensure resident quality of care, and prepare for recertification and create sustainability plans. We believe that CMS's invitations to Troy and Laguna Honda highlight that they are committed to the hospital's recertification journey and see it as a stamp of validation. We look forward to that validation coming in the form of recertification. So that concludes my briefing update, and I'm happy to take questions and comments from the JCC at the appropriate time.
Okay, thank you, Mr. Pickens. We do have some public comment from members of the public here. Dr. Teresa Palmer and Mr. Norm Degelman. If you want to go ahead and, yeah.
And folks, before you begin, please know that every member of the public has 3 minutes, and I will have a buzzer and we'll say time. And I do that, please know that your time is up and to finish your sentence and move on so the next person can speak.
Can't hear her. Oh. Dr. Palmer, can you speak towards the front so the mic can pick you up?
And Zoe, turn on that microphone, please.
Should I be carrying that? A point of clarification, did I hear that the big plan of correction had been approved and that it just then needed now it just needs validation? Did I miss? I'm a little confused. Mr. Pickens talked about validation, but I thought I heard that the big survey from where everything was submitted in January was approved. Did I hear that wrong?
Can we get that clarification? It's not a response to the question. It's a clarification.
Yeah.
Thank you for that question. I understand how confusing it could be. So remember, we've got two plans of correction that are out there. We have the most recent plans of correction for the 22567 deficiencies that were received last month. That is a plan of correction that has been accepted by both CMS and CDPH. We also have the plan of correction from the December recertification survey. That plan was accepted by CDPH and then sent on to CMS, where it has been sitting. We have not been notified as to whether or not CMS has approved it or not. What we have been told is we cannot expect CMS recertification until the most recent plans of correction have been validated and cleared. And upon that process, we then anticipate being informed of the status of the December survey. Hope that answers the question.
Thank you for that clarification. Mark, I know that it's not normal for it to go back, but I just think that clarification was important.
Yeah, I appreciate it.
Sure. And
Yeah,
so,
yeah.
Dr. Palmer, there's only 10 seconds that you took, so you've got 2 minutes and 50 seconds. I'll start the clock.
Oh, thanks. Yeah. Well, I'm worried. And I represent the Gray Panthers, who are also worried, in the Older Women's League, and people who are growing old in San Francisco, and who might need a nursing home bed at any time. And it's extremely worrisome that CMS is dragging its feet, and that Laguna Honda is continuing in terms of some of the planning that's going on to be the poor stepchild of Zuckerberg San Francisco General, rather than an independent nursing home. And I remain extremely worried that the leadership at Laguna Honda will continue to be under pressure to admit in patients that are inappropriate because of the bed pressure at San Francisco General, and that we'll just repeat history. And I think it's very important that managers who have gotten the habit of, who have been obedient but not competent, be removed or be thoroughly retrained, and that the new leadership be given the support by the mayor and the Department of Public Health, but we know that Dr. Colfax works at the pleasure of the mayor to support Laguna Honda to be the independent nursing home that it's meant to be by the city charter, where San Franciscans who need a nursing home and are likely to spend down to Medi-Cal or have already spent down to Medi-Cal will be taken care of. And and I'd also need continuing reassurance that those 120 beds will not be lost. And so I know everyone is working very hard, but I wonder if the teams are still taking for granted some old culture and some old ways of doing things that need to be jettisoned in order to make sure that Laguna Honda is the state-of-the-art independent nursing home facility that we need for San Franciscans, given the horrible Medi-Cal nursing home bed shortage in San Francisco. Thanks.
Mr. Degelman?
Good afternoon, commissioners. My name is Norman Degelman, and I'm a resident of San Francisco and also a member of the Gray Panthers. And I basically just wanted to support Dr. Palmer's statement, you know, and kind of echo what she had to say. And also, you know, my concern is, well, you know, I have a nursing home when I get to that age. So that's all I have to say. Thank you very much.
Thank you for your comments. Mr. Morwitz, do we have others online?
Yes, we have one person, and I will unmute that person. Mr. Matshaw, please begin your comments.
Thank you. In the executive team report, the last slide titled State of the Hospital shows a net reduction of 7 residents during March 2024. But a public records request shows that between February 22nd, 2024 and March 22nd, 2024, LHH's population dropped by 14 to a total census of 431 residents. That leaves a discrepancy gap of 7 residents between the state of the hospital graph and the census reduction of 14. Does that gap mean 7 LHH residents were transferred to external acute care hospitals and aren't expected to return to LHH? Why isn't there a trend line on this chart showing the number of patients transferred to acute care hospitals as an additional data point labeled unplanned acute discharges separate and distinct from unplanned AWOLs? As for next step gaining Medicare recertification, after CMS accepts the plans of correction, how long is the process for CMS to validate successful compliance with the plans of correction? And does LHH and this LHH JCC really anticipate that yet another survey inspection is going to be required, potentially delaying potential resumption of patient admissions all the way into June, July, or beyond? Realistically, when will admissions resume? Because the last we were told, in order for LHH to gain a so-called clean slate for recertification, the backlog of somewhere between 70 and 90 anonymous complaints CDPH needs to complete investigating could take several more months. That's because we're being told later today CDPH surveyors investigated only 9 anonymous complaints filed in 2022 on March 26th, including a patient death. Are we still looking at several more months of CDPH site visit inspections to clear out the backlogged 70 to 90 anonymous complaint investigations? If so, this health commission should tell us that honestly. Now, thank you. Agenda item.
That's the only
Mark.
public comment. Yes.
Okay, thank you. Are there any questions or comments from members of the committee? Dr. Chow?
Yes, thank you. Let me ask Mr. Pickens, to clarify once again, this plan of correction and what is the timeline, and realizing that regulators are very sensitive people. And the more we push, sometimes they push back, right? So you, I think, were clarifying to us there are two plans of correction, one resulting from the recent review of the complaints that resulted in some G level citations, right? And then we had the large review, which was the overall review that CMS needed in order then to have a plan which they would accept or send modifications, potential modifications. And before that could happen, this latter one, CDPH had to agree to it because they're the people that send it to the feds, right? Rather than us directly sending it over to the feds. I mean, it had to be scrubbed by CDPH, and that was already done, been sent to the feds. So could you then tell us at what time we're expecting a validation, which is also required before CMS can actually then make a decision, right?
Yes.
And because that by itself doesn't guarantee a decision also.
Yes. So thank you for those questions, Dr. Chow, and you are correct. There are two sets of plans of correction. Actually, individually, there are three. The last set are actually two of those two deficiencies that were received last month. And then the other set is the set from the December survey that you referenced. The process is, as we've shared before, plans of correction are submitted to CDPH on behalf of either CDPH themselves or on behalf of CDPH serving in the capacity of a CMS regulator. After those plans are submitted, they have to be accepted. They can either be accepted with the documentation that was provided without any clarification, or sometimes, most of the times, it's back and forth. As I mentioned earlier, for these most recent plans of correction, they were accepted by both CMS and CDPH without any back and forth. They accepted based upon the documents that we supplied.
Those are the two other most recent.
Correct.
Okay.
And so we're now in that validation window, which we've been in since late last week. Once they informed us that they accepted those plans of correction, then the clock began to tick. But they could have come out the next day or the next hour after they called us and said, or notified us, you've been approved. So we have been in this waiting period since late last week for them to come and do the actual on-site validation of those two plans of correction.
Well, what about the validation for the large plan of correction from their survey?
Yes. So our information is they must first clear these two most current plans of correction before they will then take action on that plan of correction from December. So that's why the focus now is to have them come as quickly as possible, clear those most recent plans of correction so they can finally then move on to what's been holding out there since December when we submitted that plan of correction. And that's what's required for the full Medicare recertification.
Do we know when on the large plan that was submitted to the federal, authorities from the state?
We can check with Nas can validate for us. She's on the line. I believe it was submitted in January because once they gave it to us, we had 10 days to turn it around, which we did. And so it's been out there since January.
And so in January, let's say 10 days we sent it, then CDPH had to review it. Did they have any comments back to you? And then you had to give comments back to them? And when did that comments, interchange and it was sent to Washington? I assumed it's Washington,
Sure.
wherever it goes.
Yeah. So all of that CMS back and forth and their approval, CDPH back and forth, and their approval of the plan of correction occurred in January. They then sent it on to CMS, which is where it's been.
So it's been sitting at CMS at least since February.
Oh, yes.
And during February, prior to the new plan of corrections, did they interact with you about any changes, or they're just sort of reading it, or?
CMS did not interact with us on changes. The interaction for changes was done prior to CMS receiving it from CDPH. So we have not received any formal notification back from CMS. However, our best understanding of the process is that they will not take action on that December survey until the most recent plans of correction are cleared, so that they have assurance that we have cleaned up any past deficiencies, so that when they take action on the December plan of correction, they can know all previous deficiencies have been resolved and they can move forward, hopefully towards final Medicare research.
So these most recent POCs that were submitted, are they in relationship to a recent or to looking at some of the backlog that we had?
Those were from anonymous complaints and a facility reported incident from I think months and years ago.
So they were looking back, and as they're reviewing the back ones, they're finding this, and this is what CMS in Washington is saying, or wherever they are, that they will want those two, that's your understanding, that they want those two cleared up. Then they might move on a validation for those two, and they might even combine them to an entire full validation if they wish.
That is our understanding. And if you think about it from their perspective, you would want to say that all past deficiencies have been cleared before you would grant a new stamp of approval certification that everything is in order. So that logic, while it's just disappointing from a time perspective, the logic of them wanting to make sure Laguna has a clean slate before they put their final stamp of approval does seem to make sense.
But have there, since we've submitted in, let's say, February or so, what have we interacted more proactively with CMS at all, just to check if they hadn't lost it, or, you know, before the POC came, the new ones?
Yes. So we have gone through our channels of communication, both with CDPH and CMS. And so remember, CDPH is the CMS agent in California. So all of our communication goes through CDPH as it goes to CMS, because they are acting as the agent on behalf of CMS.
All right. So it's actually waiting for the POCs, and then when they've accepted the POC, well, you were saying they have accepted the 2 POCs, so they could now actually act on the large one and then do a validation of both the new ones, which are from the past, and the entire POC, the entire review that we had in December.
They very well could, and I hope they're listening and take your suggestion, because that would make us all happy.
Okay, so, well, I think it helps us to understand what we're waiting for, and that we've been working at this even as the timing has now slipped, because they've done one of the POC, I mean, 2 POCs back from prior to the decertification time, right? Okay. I don't have any further questions. I'm just hoping that we understand.
Thank you, Dr. Chow. Dr. Green?
Well, thank you for that explanation. And, you know, if you could, I think we obviously share the concerns of the public. I think we all do. I think it was very well said, very well put today. I think the concern we have is, you know, we still have some investigations that haven't started. And when you look back at why decertification started, they were issues that were under a completely different structure, completely different leadership. There have been so many things that have been done since then. And I think what led to decertification were issues that were pretty significant. Do you feel that there's anything among the pending items here that could ever rise to the level of the original reason for decertification? And then secondarily, do we have any sense of whether there are evil people at CMS that might use some of these as a gotcha? In other words, I guess what I'm asking is, they must be principled in some way, I would think. And just wondering, just from what you know about everything. I mean, obviously they're fries, so we know a lot about them. Would you say there's anything that rises to the level of what started all of this? And do you think that that CMS would want to foot drag and find more excuses to, drag this out farther?
Yeah, so thank you for the question. So obviously, as you said, we know about the fries, the facility reported incidents. And we are not aware of any of those fries that would rise to a level that would potentially put us at risk of non-regulatory compliance. In terms of anonymous complaints, we have no idea if there are 0 out there or if there are 4 or 5 in terms of most recent. It's my understanding that the old fries and anonymous complaints had been cleared, and I'll ask Nas to either confirm or clarify that for us. So I think we're really talking about most recently, what are the fries that we know about, and then the anonymous complaints that we don't know about that are still hanging out there. And
No, it's good. Now I see Naz turned her camera on, so she's probably going to add to your comment.
Yes, good afternoon, commissioners. So to elaborate more and answer your question, Commissioner Green, my understanding is similar in that when the surveyors came to review the 9 anonymous complaints, that was the remainder of complaints to date. But again, we only know as they share with us. And then in regards to our facility reported incidents, as I've shared with you all prior as well, our goal is to have a fresh start, as Roland indicated. So working with CDPH and CMS to clear our backlog, and so that we have a good footing moving forward. The reason I'm also being overarching is I'm still waiting. I would still like something in clear writing in my inbox. Be very, very clear and articulate to you when the cutoffs are. So that's why you'll see in the regulatory affairs report, we still are showing you the hundreds of open cases because I want to ensure we get it in writing before we completely clear our charts.
Well, that's very helpful. Thank you. Because you look at the chart and it's confusing when it says investigation not started. And of course, I can't recall beyond what started all of this. Have any anonymous complaints, risen to the point of real concern beyond this most recent one that required a 2567? Have we ever had any very serious corrective action plans consequent to anonymous complaints beyond, again, back in 2019?
Go
Go ahead. I think Nas is more familiar with the stats than I am, so she's in a better position to answer.
Sorry, Roland. I was just going to say that, of course, there were the anonymous complaints in 2019, as you alluded to, Commissioner Green, related to what the facility already reported. In general, most anonymous complaints are already tied to facility reported incidences. I am not aware of a standalone complaint that has had such significant impact on the facility.
Well, that's very reassuring. I really appreciate that information. Those are the only questions I had.
Dr. Tao, you have another question?
Yes, I wanted to just sort of change the topic a little to try to clarify the role of Laguna in our entire system. Actually, my involvement with the commission, or even actually before that, any involvement with the city actually began as I was on the Blue Ribbon Committee, as you know, as chairman under Mayor Feinstein. And I have a picture of where we believe Laguna was as part of our city health system. As a component of the delivery system, and one which then would be able to help answer the needs of certain of those that we could take care of course, who had a great need beyond home care or even beyond custodial care. And so I'm wondering, in our world today with the San Francisco Health Network, and as you as head of that, where you view Laguna Honda. Laguna Honda is not an independent standing organization. it is part of the city's public health networks, but how do we interact, and how do we then maintain a collaborative relationship? There had been talk about merging both facilities. I think today's wisdom is that it was good that the commission didn't actually advise that many years ago. That was almost 2 decades ago. But in today's world, where, of course, this is an independent license from the independence of the San Francisco General, for example, how does the network see that these interact?
Yes, so thank you for that question. And I thought a lot about it. So as you point out, when the commission was formed, the healthcare industry was completely different. There was very little. Kaiser was probably the only managed care game in town, and it was mostly a fee-for-service industry. And things have evolved significantly, and particularly with the Affordable Care Act, which actually led to the development of the network. Back in the 70s and 80s, all of the major health systems in town actually ran their own skilled nursing facilities and referred to their own facilities predominantly, and with lesser referrals going to Laguna. But that all changed when they divested, when UCSF divested from its skilled nursing facility, when Sutter divested from its skilled nursing facility, when the Dignity hospitals, prior to being Dignity, Catholic Healthcare West divested from their skilled nursing facilities. The pressure was then put on Laguna to serve even more. At the same time, the ACA came along and reinforced the need for integrated delivery systems, of which Laguna Honda is the primary skilled nursing facility for the San Francisco Health Network. So I think we have tried to balance the independence of Laguna Honda as its own licensed hospital with its own medical staff who make decisions about admissions into Laguna, but at the same time, recognize the importance of Laguna in its place within the network, because reimbursement has changed. Previously, fee-for-service was the major reimbursement for skilled nursing. As of January of last year, that's not the case. Skilled nursing has been carved into Medicaid managed care, so that there's one rate that we receive as a network for residents, as opposed to, and so we have to then manage where is the best, least restrictive place of care for a particular resident in a fiscally prudent manner based upon the reimbursement mechanisms that we have, but then also from a capacity issue for our overall network responsibility, both for our patients in our primary care clinics who maybe have health at home and at some point may have to need to go into a skilled nursing facility without first going to Zuckerberg, San Francisco General, making sure they have the ability to still go to Laguna Honda. And again, with this new system of having to take care of our network responsibilities first, because that is a requirement of Medicaid managed care, we're constantly trying to balance all of that.
So the relationship is important, complicated, but one in which we are trying to see that the facility can help serve the residents. And now that we've had this new managed care from Medi-Cal, be able to also respond to that as a need for those who are under our Medi-Cal program, right?
Correct.
Yeah, and because Laguna's been a very important institution for some of us who actually then assisted in getting the bond issues passed and the buildings built.
Yes.
I still remember back in 1989 where there was discussion about whether or not there was adequate earthquake protection, and of course there wasn't at that time, but the Blue Ribbon Committee had left that decision to another day. Then it turned out I got a point to here, and that became the other day. And so it's really important for, certainly personally for me, to see that Laguna can be back in full operation again, as has been the service that it's offered so many years. So thank you very much.
Thank you. My only comments are one to thank you for those updates prior to the report. That was really helpful to put the context around where we sit today. and to really sort of also understand sort of how the timing of things is not always in our control, to say the least. But that we still think that there are things that we could and should do to push the timeline in our favor, and just hoping that we're doing all of those things. In addition to taking care of the business we're supposed to take care of, I mean, there are things that we can do on a communication basis. And as a representative of our constituency and residency here in San Francisco, that I think is really important to do. And also thank you for answering Dr. Chow's question about the positioning of Laguna Honda within the context of the network and sort of that mini history of managed care and the transition from fee for service to the state, and who knows what it's going to be in the future, right? And what regulations are going to be coming in relationship or in response to the changes in healthcare. All of us have been involved, I think, in those changes over the last several decades. And I think it's just mind-numbing and mind-blowing to try to understand how such an industry can respond in a way that is always going to be protective of the people that we care the most about, also given the complications, sort of the societal complications that are sort of pressing upon us. So thank you again. Also, thank you for your understanding of all of that and being able to sort of, I think, succinctly share that with us. I did have a question about the report in terms of the Lean Summit, Sandra, that you were just wondering, knowing that Laguna Honda is, I don't know if it's the only, but certainly the largest of its kind that's had to go through this recertification and to employ the Lean processes throughout. At that summit, can you give us just sort of a sense of what the audience and how the audience responded to your presentation, or what was the conversation around, our recertification in, sort of in terms of the global situation with skilled nursing and the kinds of regulatory pressures that are coming down, particularly post-COVID?
Thank you for your question. It's interesting because Laguna Honda being a very large nursing home, other nursing homes, the other healthcare providers that attended this summit were acute care. They're with skilled nursing within their offerings of services, but there weren't any other standalone skilled nursing facilities that I know of. I don't know. I think it was mostly acute care, but skilled nursing facilities are starting to embrace and see how the Lean principles really tie into a QAPI processes, and they partner and they marry really, really well. So I think that was part of your question, where the attendees, the other, my understanding was this Lean conference was the first time I think the manufacturing and health came together to learn from each other. So there were other folks there that were non-healthcare businesses, but wanted to come learn through our process. They were very intrigued on how we've used Lean principles to manage this process. So it was very well received. It was so far the feedback that we've gotten from the evaluations have been very positive. We'll receive the final evaluations towards the end of the month, but we have received notice. We've a lot of positive feedback, some requests for more information of how we might have used Lean principles in other areas within. So there's been, it triggered a lot of engagement and a lot of intrigue with other folks reaching out and asking us what other ways that we have used this Lean principles in other quality improvement projects. People were really thankful that we were candid in sharing our journey, and was very inspiring for many. And there were a lot of requests and a lot of photos for our processes and tools that we use. So it was really an overall very positive experience. I don't know if that answers your question.
No, it does, because we pretty much concern ourselves with what happens within the 7 mile perimeter of area of San Francisco, as well as what happens in Sacramento and DC, but sort of in the context of the larger skilled nursing or long-term care, and in fact even larger healthcare world, it's sort of, we don't get a lot of that sort of contextual thing. And I think given what you just shared, that as traumatic as this last few years have been for us, that I think, being able to look forward to being able to share the lessons based on the success, the final success of recertification, and the kind of sustainability and stability that we are going to witness, thinking positively, soon in the future, that there is sort of a larger world out there, a larger industry that is going to be looking to us for, I think, a different type of validation, and looking forward to being able to do that. So that was sort of the context of my question. It's like, is this something that just gets self-contained within, our world here, or are there lessons and possibilities that are larger than, this sort of, myopic sometimes world that we view ourselves in?
And I just would like to end, it was really just an honor to go with Young Jay and be able to share the story of Laguna Honda and the process of putting in the lean principles, and just really being able to honor the staff and share about the interdisciplinary stand-up and the different huddles and all of the tools, and be able to really highlight and share how the staff have embraced this work and stepped up and share their story with the attendees. It was just an honor, and it was really nice to be able to thank them and honor them in that way for the work that they've been doing. So thank you for
Great.
asking.
Thank you, and thank you for sharing that. Look forward to hearing from Troy about his experience today as well. So,
Thank you.
okay. Any others? Okay, we can move on.
Thank you. Item 5 is the hiring and vacancy report.
Good afternoon, Commissioners. I stand here to present the Human Resources Services report for April, looking back at the data from March. LHH vacancies stand at 8.9%, seeing a drop from the 9.6 in March. We hired a total of 37 employees in various classifications between March 1st and March 31st of 2024, had 3 separations during the same period, including 1 retirement. We continue to prioritize and support the hiring of registered nurses. The vacancy rate currently stands at 3.3% for the month of March. We hired a total of 11 registered nurses last month. With regards to the nursing managers, or the 23-22 classification, we hired 1 nurse manager last month and continue to move candidates through the selection process for the 6 remaining openings that we have. Interviews are currently in process for all of these vacancies. There are currently 12 openings for the 23-12 licensed vocational nurses, for which we are in the middle of the selection process. We successfully onboarded 15 licensed vocational nurses last month. The hiring team is also continuing to process vacancies within several classes through an efficient batch hiring process. Currently, we're beginning to onboard 23 new hires in the 2903 hospital eligibility worker classification, 11 in the 7334 stationary engineer classification, 5 of the 2593 health program coordinator classifications. We're also beginning the second batch hiring process for the 25 vacancies across DPH for the 2585, the health worker 1 classification. As we look to fill the vacancies across DPH, the batch hiring process also helps to identify efficiencies and ensure a better outcome for both candidates and hiring managers. The HR team also regularly holds meetings with exec leaders and hiring managers on a weekly, monthly basis to go over vacancy information and hiring plans. Among the hiring highlights for the month, RN highlights, 11 2320s or registered nurses started last month. 1 nurse manager started last month. 2 nurse practitioners started last month. Within the non-RN highlights, we had one physician specialist start last month, and we had 15 licensed vocational nurses started last month. Thank you.
Thank you, Priya. Is there public comment?
Is there anyone in the room who would like to make public comment on this item? We're on item 5. I don't believe that you've received any slips, have you, Commissioner Guillermo?
No,
For this
only
item?
for number 7 coming up.
Okay, then we have one remote public comment. Mr. Manette Shaw, I've just unmuted you. Please begin.
Thank you. I will be submitting written testimony on this item FOI inclusion in the meeting minutes. Thank you.
Oops, you're muted, Mark. Okay.
That's the only comment for this item. Thank you.
Okay. Comments from the members? Okay. Dr. Green?
Well, thank you for the report. Do you have any sense of the timeline for when you might complete the hiring of the nurse managers?
The nurse managers, we are having interviews at the moment, so which means that we're probably a month away from starting new nurse managers. This is kind of the last phase of the hiring process. After the selections are made, we move them into the pre-boarding and the onboarding. So we're looking ideally at a month away from starting all of them.
And then given the complexity of their jobs, are any coming from inside so they know all the policies and procedures? And if not, what's the timeline for having comfort that they can really take on those leadership roles and know, pass all the tests for all the things you have to know to be able to do that very difficult, challenging job?
I'm not able to disclose if there are like internal candidates at the moment because they're all part of the candidate pool, so to say, and they're moving through the selection process. But as with all the vacancies, they are open to internal employees to apply, and we always encourage internal employees to apply to these positions, which means that it's a faster transition and a faster, kind of process. Yes, Terry.
And is there any difference if there are internal candidates? Is there any difference in the amount of time it takes to onboard them?
That's what I can answer for you. This is Terry D'Antoni. I know that Tracy Brown is on as well. Yes, if you have been in Laguna Honda, it is a little bit quicker to get onboarded. However, to learn the role and the way in which we need it to be done, we are looking at revamping the way we do nurse manager onboarding and training so that we've totally, with all the milestones and the way that Laguna Honda is working now, it does require a much more extensive training program for the nurse managers, whether they're external or internal.
So timeline, I mean, is it that a month of training, 6 weeks of training? I mean, is there any sense of that?
Yeah, it's probably about a week or two. I mean, what Tracy and I were talking about, if they're external, we'd like them to come in and be trained as a nurse on the floor to understand what the complexities are, and then to be shadowed and mentored. So I would say 4 to 6 weeks till they're independent. And independent means paired up with their nursing director and with the DONs.
Thank you. That's really helpful. And then the other question I have is, I didn't really even realize you utilize nurse practitioners. I mean, it's certainly PAs and NPs are vital to the general. How do you utilize them, and how many do you actually have? I was trying to find the code number in here and I couldn't find if we had vacancies or not, but I'm curious to know how you utilize APCs at Laguna.
I don't believe currently we have APCs. We did with wound care. One from San Francisco General came over and worked. And then I know we have some in our employee health helping with employee physicals.
So I think if Nita is on, she can probably address that because those came forward from the medical staff.
Yes, that is correct. As Terry D'Antoni said, our APC is limited to working in the occupational health clinic.
Great. Thank you very much. Those are the only questions I had.
Thank you. I wanted to actually note that in the vacancy rate hires and separation charts, really, this is perhaps one of the best months that has occurred for the last 2 years. So I think aside from the graphs being helpful, really does demonstrate that I think we're moving along. I'm also pleased that we are in the process of interviewing an animal care attendant. I always thought that that was really unfortunate that the poor animals, I hope, are getting attention and that they're going to have an attendant back again. So, but congratulations, I think, on the hiring process. I would imagine, and I'm hoping some of this also is a reflection of the new process being used by nursing in order to bring on board more quickly the candidates. So
Yes.
again, thank you.
Thank you.
Okay, no more questions? Okay, we can move on.
Great, thank you, everyone. We can move on to item 6, the Regulatory Affairs Report.
Good evening, Commissioners. I'm Geraldine Marnano, Director of Regulatory Affairs. I will present the March 2024 Regulatory Affairs Report. For the facility reported incidents, Laguna Honda reported 13 incidents to CDPH and received 0 anonymous complaints for the month of March. There was one on-site visit with CDPH surveyors in the month of March. The visit was a 2-day abbreviated survey to investigate 9 anonymous complaints from 2022. And I'm happy to report that there were no or 0 deficiencies shared with the facility during the exit conference for the 9 anonymous complaints. Mr. Pickens stated in his chief executive officer report, Laguna Honda received 2 2567 statement of deficiencies in March, and the plans of corrections were submitted and approved by CDPH. Please let me know if there are any questions or comments that I can address at this time. Thank you.
Thank you, Geraldine. Are there any comments from the public here? No?
Commissioner, I thought that that some folks had turned in slips for item 6.
No, only 7. Item
Only 7,
7.
I apologize.
Yeah.
Okay, then there is a caller, remote caller, if there's nobody in the room. Mr. Manetchal, you've got 3 minutes.
What about my chart, Mr. Morowitz?
Zoe will pull that up right now.
As you can see from my chart, I asked Mr. Morwitz to display on the overhead since LHH was decertified exactly 2 years ago on April 14th, 2024. There have been a total of 415 facility reported incidents, FRIs, reported on the monthly regulatory affairs reports presented to this LHH JCC and submitted to CDPH. Of those 415 FRIs, fully 129, representing 1/3, involved the 8 more serious categories of FRI incidents, including 53 major incidents, 41.1% of the 129 FRIs, including 26 adverse events, 16 disease outbreaks, and 11 major injuries, which increased despite implementing 1,000 corrective action milestones since consultants were hired to fix LHH, costing $40 million. Unfortunately, members of the public aren't ever told how many of the 11 major injuries or additional 26 so-called adverse events included falls of residents, like the 2 falls reported in today's Regulatory Affairs Report. Finally, revealing the 3G severity and scope citations LHH received were because one of the falls involved a resident dying within 2 hours of her fall from a low bed because of failure to staff using 2-person assists when performing patient care. Slide number 7 in today's Regulatory Affairs Report about anonymous complaints outstanding not investigated by CDPH is concerning, because it shows 70 to 95 anonymous complaints dating back to 2021 yet to investigate to grant LHH a clean slate to qualify for recertification and patient admissions resumption. The March 16, 2024 site visit preliminary findings of no deficiencies may change. Given the patient death in 2022 investigated may receive a final citation following field office review. Thank you.
Okay, thanks. Any questions or comments from members of the, Dr. Chow?
Yes, thank you. And thank you again for the new graphs because they are now much more readable. We can even see the numbers, and we can actually see those in which we had no deficiencies and those in which there were some deficiencies. So I was curious amongst all of those, and of course they don't go by grade of, I mean we could, but they don't go by grade of severity. But I just wanted to know about what percent of all of these deficiencies we actually are found not to be deficient. And I think the commissioners have also received a chart which I got from staff here, which showed that for the completed years, or what we feel are completed years, there was somewhere between 88 to 95% that were actually not deficient in finding. Like I said, of course, it doesn't take into consideration severity, and that would be something else one might want to look at. And in the incomplete years, of course, then in 22, it was at the moment 82%. And the remaining is, I think, as Naz said, we're counting perhaps differently from the state in terms of what's pending. So, but I do think on the completed years, it's important to really note that while we, of course, believe every one of these needs to be investigated, that there are a very large number shown in our graphs here now that are then found not to be deficient. So I want to thank staff for that.
Thank you.
Thank you, Dr. Chow. Dr. Green?
Yes, I found this chart to be very, very helpful. And I think if there were a list of pendings here, you know, it's interesting to look at it graphically, but it's hard to get the whole context when it's by month. But if it would be possible to include a chart like this in our report every month, it would be so helpful. It's so simple and straightforward, and it does give you a very quick overview of exactly what Commissioner Chow has brought up, that in fact, when you look at 2019 through 2021, as we really do close down the years, that it gives you a better sense of how many there, the percentage at which there have been no deficiencies. So I don't know if it's possible, but it really is helpful.
Geraldine and Naz, do you think that'll be possible?
Yes, we can start to add that table. And we'll add the scope and severity as Commissioner Chow has called out.
Thank you.
Okay, no other comments? Okay, now we can move on to the next item.
Great, thank you. Item 7 is Laguna Honda Hospital policies, and this is an action item.
Good evening, Commissioners. For policy and procedures, I have 30 today. 18 of them are hospital-wide. There is one new one, 2417 Comfort Care. After the questions and comments provided by the Commissioners, we did make an update on that. We added care plan updated with resident or surrogate decision maker is within the shift, which is on page 31 of the updated packet. There are 16 revisions. The first one is 20-11, LHH response to ZSFG surge conditions, 21-04, HIPAA compliance, 22-04, resident sexual rights and responsibilities, 2413 falls. With that, we also updated on page 10, the word about for the residents. We attached 60-03 policy reference to the reference page on page 14, and we attached the standard work, which is pages 20 to 28. Next policy is 24-14, opioid overdose prevention, 2418, resident locator system, 2428, behavioral health, 29-01, provisions for acute care services not available at Laguna Honda Hospital. We updated with the LHH and DPH abbreviations on page 34, 29-02, resident as photography or interview, 29-08, proposed non-emergent medical interventions that requires informed consent for a non-incapacitated resident who lacks a healthcare decision maker. 35-04, inventory and disposal of hospital property. 50-11, procurement card. There was an update. We replaced the food will adhere to the with all food purchase will meet criteria outlines in the DPH healthy food and food expenditure policy, which is on page 36. Next one is 65-02, monitoring of third-party agreements and appendix. 70-01, C11, Laguna Honda Hospital, the MDF, IDF support facilities. 80-03, student volunteer and consultant orientation. 80-05, staff education program. There was one deletion. 24-16, Code Blue Appendix 13. For departmental policies, there were 12 of them. The first one is clinical nutrition. It was one revision to the diet manual. Nursing had 10 policies. 3 of them were revisions. The first one is C 3.0, documentation of resident status, tailored by licensed nurse. K 4.0, applications heat or cold therapy. L 1.0, emergency interventions for choking. There were 7 deletions. First one is H 2.0, collection of stool specimens. H 3.0, sputum specimens. H 4.0, gastric specimens. I 7.0, incentives spirometry. M 1.0, and the attachment 1, orthostatic hypertension protocol. M 11.0, blanket warmer protocol. M 15.0, installation and checking of portable bed exit alarm. For pharmacy, there was 1 revision, 11 USP 797, sterile compounding policy and attachments. And those are the policies presented for approval today.
Great, thank you, Carmen. Is there public comment? Yes, so Dr. Palmer again and Mr. Degelman.
I'm nervous about facility-wide 20-11 Laguna Honda response to ZSFG surge condition. Now, this has been around since 2012, but that's when things were going downhill because Laguna Honda didn't get into its current trouble overnight. It took over a decade. And I'm really worried that this resurrects the worst aspects of the FLOW project, where Laguna Honda leaders have little control over who is sent from our county hospital, and Laguna Honda is used for hard-to-place county hospital patients, while so many in San Francisco wait for a nursing home bed. And I really would like you to delay looking at this and really go over it with a fine-tooth comb. Make sure that the people who are making the decisions about who to admit to Laguna Honda are people that have really good sense about what it takes to do direct patient care for these patients. This is where you've gotten into trouble before and you don't want to repeat history. We want Laguna Honda to be run by leaders with great skill in nursing homes who understand who a nursing home can reasonably care for, and we want those leaders to have control over who comes to Laguna Honda. Mr. Pickens stated himself that Laguna Honda got into trouble because it was run like an acute care hospital. Let's not repeat history. Not giving Laguna Honda admission teams enough power to reject overflow from San Francisco General means Laguna Honda is the obedient subject, not the independent, state-of-the-art skilled nursing facility that Dr. Colfax keeps telling us that he wants and that we all want. And so I ask you to really look closely at this facility and make sure that Laguna Honda clinicians who really know about what Laguna Honda can safely take care of have the power and the support that they need. Thanks.
Thank you. Mr. Degelman? Okay, you're declined. Okay. Is there any online comment?
Yes, there is one person. Caller, you're unmuted. Please let us know that you're there and begin your comments.
Thank you, Mr. Morowitz. I can almost talk again, sir.
Okay, great.
Proposed revisions in LHH policy #20-11 are extremely concerning. The revisions indicate the extremely flawed flow project of SFGH patients to LHH is alive and well and being beefed up to provide a fourth justification for declaring red alerts at SFGH via a new clause adding, or the AOD/HS determines that SFGH has marginal capacity to accept incoming patients. Someone declaring marginal capacity is a vague, subjective term if ever there was one. It's a fourth route to trigger shoving SFGH patients into LHH during a red alert. This new provision to accommodate SFDPH's insistence on flow of inappropriate patients into LHH may further delay LHH's recertification. LHH leaders have little control over who is dumped from SFGH into LHH via the Flow project, designed to move hard-to-place SFGH patients into LHH while many elderly San Franciscans wait for a nursing home bed, but end up dumped out of county for SNF care. LHH's medical director must have final say over LHH admissions, not SFGH CEOs. LHH staff with actual experience administering nursing homes and understand which patients can be safely cared or shoved aside in this policy revision. Forcing LHH admission teams to admit overflow SFGH patients portends LHH will continue receiving inappropriate level of care patients. Thank you.
Okay, is that the only comment?
Yes, it is. Thank
Okay.
you. Commissioner.
Okay, questions or comments from the commissioners? Dr. Cho.
Yes, thank you. And I want to thank staff who quickly gave us some responses for our needs, but questions, and it's a little hard to actually figure if they actually had responded to what we said. So I'll ask the chair how we might want to handle that. Because, you know, she listed a number of corrections probably in relationship to some of the questions that we had risen, that we raised, but we don't know if that has answered our questions.
Okay, so would you, okay, let me get a comment from Dr. Green first, if it's on the same thing, or do you have specific questions on specific policies?
Well, yeah, I think Commissioner Chow and I were both confused and thought there needed to be some clarification on this whole issue of Laguna Honda and the general. And, you know, I'm curious, I think in 2012, maybe this all happened because of, you know, a disaster at the airport or something along that line. And so I think it would be helpful for us to not only understand the context whereby this policy came to be, but I'm somewhat confused about how the very strict admission criteria we have, which include that only certain individuals can make a decision to admit, and that it has to be, as Commissioner Chow said, people who are well aware of how Laguna works and who we can manage, that they would be the final decision makers. And I gather this policy has never been needed either. So, I mean, I think we do need clarification so that we understand that this isn't anything different than a major disaster type policy. But clearly we need clarification. I think Commissioner Chow probably understands it better than I do.
I think,
Yeah, I just wanted to say that my initial comment was on the overall,
right.
which was related to the fact that a number of corrections were made related to some of our comments. And that if we were to, first of all, say that we need to read those within the context of what we had said, and there may still be some questions. As an example, under comfort care, it says that there will be an evaluation, and my comment response was, well, we do that every shift, but it doesn't actually state that. And when you read it, it isn't clear if it's every shift, every week, or at the time of a review. So that's just an example of how perhaps some of our questions have been answered but not put into the policy. Others have already been put into the policy that staff worked very hard on. I also agree that the policy that Commissioner Green just spoke about, 2011, needs to be clarified as to its purpose, and also that there needs to be, as a statement that, as in accordance to our admission policies, that in fact admissions to the hospital are going to be determined by the hospital whether or not such is an appropriate person, because regardless of what the emergencies are, unless there's another section that's related to that, but I would find that sort of contradictory at the moment.
So I think Mr. Pickens is prepared to answer that particular issue.
Okay.
But in terms of the overall, I think we can fall back to a process that we've done sort of in the past. If there's sort of a back and forth between the specifics of the questions that need further clarification prior to the full commission meeting on Tuesday, then we can recommend approval if those are answered in the appropriate time frame, and if they're not, then we won't be able to recommend approval. Okay, so in the meantime, let's go ahead and answer that question about the admissions policy, the surge admissions policy, and then if there's anything else specific that can be answered at the moment, we'll get to that, but otherwise we'll do what we've done in the past.
So thank you for the question and opportunity to talk about the surge policy. So my recollection, having been in a DPH employee for the last 20 years, is that policy was in response to an outgrowth from the Asiana aircraft crash. At the time, as you know, Zuckerberg is the only level 1 trauma center serving Northern San Mateo and San Francisco County. And so with the tremendous number of traumas that were coming in, the hospital needed to quickly decant as many patients as it could to make room for those traumas. That happened. Only individuals who were at San Francisco General who were awaiting skilled nursing had already been determined to be skilled nursing level of care were transferred to Laguna. Other patients were transferred to other San Francisco hospitals. Med-surg patients were transferred to UCSF, to Sutter. And my recollection is there was a delay in that transfer process. And so this policy came about as a means to, if this were to ever happen again in the future, where there was a need to quickly decant the trauma center, how could that be done in a transparent process that did not require ad hoc decision-making at the time? And so I think there's an opportunity to really restructure that policy to make it more clear and to also make it consistent with the fact that the Laguna Honda admissions team is the one who makes the decision on admissions. So there's probably a way, I think that policy talks about the Laguna Honda CEO. I think there needs to be some process where then the admissions team gets to weigh in and to really clarify that, again, only individuals who meet the criteria of Laguna can be admitted at Laguna. So I think there's a way, an opportunity to make that more clear in the policy.
So we'll see another revision of that clarity.
Yes.
Okay. Before, well, hopefully before Tuesday, actually before the end of the week, if we can get that, or by Monday at the latest, right? And then just to be clear, this is about the surge policy. It does not intersect with their general admissions policy for Laguna Honda, which you have clarified is independent and directed by the staff at Laguna Honda, not by ZSFG.
Right. Those are two different policies, but I think it would be helpful actually if the surge policy does have some link to make sure that there's continuity in that, rather than just saying the CEO is the only one who makes a decision. There should be a quick conference with the admissions committee to say, okay, here's the situation. These are the patients who are being presented for potential admission at Laguna. We need to quickly make a decision, as opposed to putting it just on this one individual, that the admissions committee still gets a role into this policy. That would be my recommendation.
Okay.
I'm thinking that, we're hoping there is not another disaster within the next week or so, that we give staff a little more time to be able to rewrite this, or perhaps to write two different portions, because I think some people, or including ourselves, are confused that as we read it, it sounded like, if I could reach certain thresholds over at General, then all of a sudden this policy, and it becomes truly a surge policy rather than an emergency disaster policy, which, and as you have pointed out, I don't know if there is another policy that separates out the other issue of general's own capacity, or are we only talking about emergency disaster type of a policy?
So in terms of Laguna Honda Hospital, I'm not aware that there's a different policy other than this one, which was meant to be only emergency surge related. Uh, the admissions policy for Laguna clearly states the admissions team makes the decision. That has been the case, has always been the case, and continues to be the case. Laguna, San Francisco General, nor anyone else can decide to place someone at Laguna that the admissions team doesn't approve.
Okay. So I actually believe, would you like additional time? Because we need to then discuss how it, so that it could either come back at the next meeting.
I would, yeah, I would think the team would want to be very deliberate in the process.
Okay, so for that policy, then we will remove it from the potential recommendation to put on the consent calendar for the meeting, the full commission meeting next Tuesday, right?
Correct. And
Give
I
you
just
more
want to
time.
check with Nas, that means we'll just have to, it'll just be delayed in its revision, correct?
Yes, that's correct. We'll try to bring it back next month.
Okay.
Okay, thank you for that. And then for the others, I know there's a number, there's quite a number of other sort of questions and responses that within that might need some further clarification. So for Doctors Green and Chow, who have all of the questions, would it make sense to go and go back to the process that we've used in the past, which, Mark, you have to remind me how we've actually done that? Or would we really need more time to clarify all of those issues, because there's so many that still need further either edits or clarification? Okay, Mark, if you can remind us
Of
of how
course.
that has
So,
worked.
so commissioners, what you've done in the past is this committee has voted to recommend to the full commission that these items be approved pending adequate and satisfactory responses to your questions and concerns. And that gives you time to review between now and Tuesday the responses and the changes that the staff have made. In addition, on that day, hopefully we can have some of these staff there to answer additional questions in case something comes up. But between now and then, you all usually do emails to me, and we do most of it through me, so that by the time you get to a vote, you can confidently say the committee does recommend that the full commission approve these. If you have any issues in between, you can pick those out. And at the meeting on Tuesday, you could say, we recommend approval all except for this policy or that policy, depending on if you still have issues.
Okay.
That makes sense.
That sounds like something that will work for us for this set of policies. Then if we can.
Right,
Yeah.
and I guess, Mark, remind us that if we actually had objection, I mean, more need, we could then pull it off of the consent. Well, actually, because even after you've publicized it, if we were not satisfied with it, we can always pull it off.
Right.
Yeah.
Yes, sir.
Yes.
Okay.
Each item can be pulled on the consent calendar on the day of the meeting on the 16th. So you're not bound by the vote today is a soft recommendation, because you're recommending that the full commission approve pending you're satisfied with these responses. So I can help facilitate you all your review, and then making sure that whatever's on the consent calendar makes sense to you. And today, in terms of motion, what I recommend you do is one of you have a motion to recommend that the full commission approve all the policies except for 2011, pending that the responses you've received are satisfactory.
Yeah, that sounds appropriate. And then we will expect the 2011 policy to be, to come back next month. Okay, with the other set that we might, be looking at that time.
You mean
Okay.
there are still more sets?
There's always sets.
I mean, Maybe Mr. Morris can clarify? We have another packet here. Is this now the packet that's complete with the new changes
Yes,
reflecting?
sir.
Yeah,
Yes,
so,
sir.
And so we can sort of eliminate the old packet?
Yes,
I mean,
yes, sir.
otherwise we're sitting here reading two different packets.
Absolutely. So what's in front of you, and thank you to staff and to Zoe, number one, thank you to Zoe, who is sitting there in my stead today, and for helping, but she gave this to you, and all the changes have been highlighted in the newer document, Commissioner Chow.
Okay,
okay,
thank
so
you
you
very
can
much.
use that for, yeah,
Yeah,
okay.
great.
Okay, great. So if we can have a, oh, Dr. Green.
Yeah, I just have one more comment, and I hope as you revise 2011 that you can make it very clear that our admissions individuals are responsible for making these decisions, because if there is a sudden crisis, I don't know whether those, the people in general who think someone is qualified for SNF, especially if they're not in their own SNF already, would necessarily qualify for Laguna. So, if you put in something about timeline for evaluation, because obviously this is meant for urgent situations. I don't know myself, but I think the more clarity you can bring to the policy, the more comfort everyone will have that it's going to go right, and that it isn't, going to be something done in haste, but something done with a lot of thought and consideration. That's all I wanted to say.
Oh, I had one more comment
Sure.
concerning that came up with Commissioner Green they were discussing. What if somehow you put in some sort of external trigger, somebody declaring an emergency or whatever it may be, so that it's not just at, the way it's reading, it's at the will of general who tells you that if I had 10 people over here or something. I think it's even more important that we have a definition of what that emergency is.
Yes,
So it's really clear that more work needs to go into this, given the comments and suggestions. I don't think you need to answer that at this point, but I think it's a valid recommendation from Dr. Chow and then Dr. Green. So we'll do that, and we'll expect something next month. In the meantime, if we can have a motion on,
So
okay,
Second.
okay, right?
All those in favor?
Second. Aye. Thank you.
Great. Thanks, everyone. And again, thank you to everyone who put in the work, especially Carmen and all the staff who revised the policies quickly. All right, we can move on to the next item, which is a consideration for a closed session.
Okay, is there a motion for closed session?
So moved.
Second.
Okay, all those in favor? Oh, public comment. Yeah.
Yes, I just want to make sure there's not, I don't see public comment. I just want to make sure I don't see anyone here. Okay, yes, no public comment. So all those in favor?
Aye.
Okay, great. And please give me about 45 seconds to take us over. Folks on who are watching remotely, you will not see or hear us when we go into closed session, but we will be back. Members of the public who are attending in person, this is your time to leave. Thank you so much for attending. And if somebody would please close the door when those folks leave, so that it's not possible for anyone to come back in. And again, I will get us back over in about 45 seconds. All right, commissioners, we are back into open session. Please consider motion to disclose or not disclose discussions held in closed session.
Is there a motion?
Move not to disclose.
And I would second that.
All those in favor?
Aye.
Aye. Okay, and a
And now
motion
you-
to adjourn? Right?
Yes.
I'm finally getting this.
Move to adjourn.
I would second that.
Okay, all those in favor?
Aye.
Okay. We're done. Thanks, Mark.
Thank you.
Hope all
And-
is good. See you soon.
Yeah,
Back
Thank
to-
you, and thank you again to Zoe for standing in there. It was very helpful and a lot of work and stress today. So thank you.
Yeah. Thank you, Zoe. I
everyone.
saw how hard you were working earlier to coordinate with Mark, so